Welcome to this technical briefing on vaccines. We have three speakers, two with opening statements. The first one will be Dr. Theresa Tam, Chief Public Health Officer, then Dr. Howard Njoo, Deputy Chief Public Health Officer, and we will also have Dr. Matthew Tunis, Executive Director for the NACI Secretariat, who will be answering questions. So this is all going on virtually, and we'll start with Dr. Tam.
Merci, and bonjour à toutes et à tous. Nationally, the daily case counts continue to increase, but there is still considerable regional variation in disease activity. Over the most recent 7-day period, an average of over 2,800 new cases were reported daily across Canada. Currently, severe illness trends have leveled off, but are still elevated and could begin to rise again unless we keep infection rates down. Over the past week, on average, 1,540 people with COVID-19 were being treated in our hospitals each day, including 465 in intensive care, and 19 deaths were reported daily. The emergence and spread of the Omicron variant of concern, including 11 recent detections in travelers coming into Canada and or their close contacts, is yet another reminder of how quickly things can shift in this pandemic unless we continue to reduce the spread and impact of the virus with vaccination and other layers of protection. In addition to strengthening diagnostics, therapeutics, infection prevention control, vaccine uptake, and other response aspects, experts on Canada's National Advisory Committee on Immunization, or NACI, have continued to update guidance to help strengthen our COVID-19 vaccination programs. Today, NACI updated advice on COVID-19 mRNA vaccine booster doses, as well as recommendations on the use of mRNA COVID-19 vaccines in adolescents and young adults. NACI recommends, and health authorities in Canada agree, that immunization in those who are eligible but have yet to receive their primary series should continue to remain the top priority in Canada and around the world. NACI has reaffirmed that the benefits of receiving an mRNA COVID-19 vaccine continues to outweigh any potential risk of experiencing rare side effects following immunization with an mRNA vaccine, including the rare risk of vaccine-associated myocarditis and or pericarditis, most often seen in males aged 12 to 29 years. Regarding boosters, NACI considered emerging evidence on waning protection of vaccines over time and the safety and potential benefits of mRNA vaccine booster doses. In the context of the Delta variant, evidence suggests that vaccine effectiveness against infection and symptomatic disease decreases with time, and possibly against severe illness as well, especially in older individuals. No additional safety concerns were noted following mRNA vaccine booster doses. The rare risk of myocarditis and or pericarditis appears to be lower after the booster dose than after the second dose of the primary series, though is higher than after the first dose. Based on this, NACI has increased the strength of their recommendations to now say a booster dose of an authorized mRNA COVID-19 vaccine should be offered 6 months or more after completion of a primary COVID-19 vaccine series to people aged 50 years or older. Adults living in seniors' long-term care or other congregate living settings that provide care for seniors. People who received an exclusively viral vector COVID-19 vaccine series consisting of only AstraZeneca Covishield and or the Janssen COVID-19 vaccine. Adults in and from First Nations, Inuit, and Métis communities, as well as frontline healthcare workers having direct, close physical contact with patients. NACI further recommends that a booster dose of an authorized mRNA vaccine may be offered 6 months or more after completion of a primary COVID-19 vaccine series to adults aged 18 to 18 to 49 years, with consideration of jurisdictional and individual risks. Finally, with respect to vaccination of adolescents and young adults, NACI considered new Canadian and international data that suggests the rare risk of myocarditis after receiving an mRNA COVID-19 vaccine may be lower with Pfizer BioNTech Comirnaty 30 microgram vaccine as compared to the Moderna Spikevax 100 microgram vaccine. These data also show that a longer interval between the first and second dose in the primary vaccination series results in a stronger immune response and higher vaccine effectiveness, and that longer intervals may also be associated with a lower risk of myocarditis and/or pericarditis. Accordingly, for adolescents and young adults aged 12 to 29 years, NACI now recommends that the use of Pfizer BioNTech Comirnaty vaccine is preferred over the use of Moderna Spikevax vaccine to start or complete a primary vaccine series. NACI further recommends that the second dose of a primary mRNA COVID-19 vaccine series should be provided 8 weeks after the first dose. Now and during the winter months, while the virus continues to circulate worldwide, and the significance and impact of the Omicron variant of concern is being assessed, the need for heightened vigilance remains. Regardless of which variant is circulating, we are better protected individually and collectively when we all do our best to maintain layers of protection by completing the COVID-19 primary vaccine series and getting a booster shot dose as recommended, wearing a quality, snug-fitting mask, avoid crowding, and taking other measures as possible. Thank you. Merci. Miigwech.
Bonjour à toutes et à tous. À l'échelle nationale, le nombre de cas quotidiens continue d'augmenter, mais il existe encore d'importantes variations régionales relativement à l'activité de la maladie. Au cours des 7 derniers jours, plus de 2800 nouveaux cas ont été signalés en moyenne chaque jour au Canada. À l'heure actuelle, les tendances des cas de maladies graves se sont stabilisées, mais sont toujours élevées et pourraient être à nouveau à la hausse si nous ne parvenons pas à maintenir les taux d'infection à un faible niveau. Au cours de la semaine dernière, en moyenne, 1540 personnes atteintes de la COVID-19 étaient traitées dans nos hôpitaux chaque jour, y compris 465 personnes aux soins intensifs et 19 décès ont été signalés quotidiennement. L'émergence et la propagation du variant préoccupant Omicron, y compris les 11 détections récentes parmi les voyageurs qui arrivent au Canada ou leurs contacts étroits, nous rappellent à quel point la situation peut changer rapidement pendant cette pandémie, à moins que nous continuions de réduire la propagation et les répercussions du virus grâce à la vaccination et à d'autres mesures de protection. En plus d'améliorer les méthodes diagnostiques, les approches thérapeutiques, la prévention des infections, la lutte contre les infections, les taux de vaccination et les autres aspects d'intervention, les experts du Comité consultatif national de l'immunisation, ou CCNI, ont continué de mettre à jour les orientations pour renforcer nos programmes de vaccination contre la COVID-19. Plus tôt aujourd'hui, le CCNI a modifié ses conseils sur les doses de rappel du vaccin à ARNM contre la COVID-19 et des recommandations sur l'utilisation des vaccins à ARNM contre la COVID-19 chez les adolescents et les jeunes adultes. Le Comité consultatif national de l'immunisation recommande et les autorités de la santé publique au Canada conviennent que la vaccination des personnes admissibles mais qui n'ont pas encore reçu leur série primaire des vaccins doit continuer de rester la priorité absolue au Canada et dans le monde. Le CCNI a réitéré que les avantages du vaccin à ARNM contre la COVID-19 continuent de l'emporter sur les risques d'effets secondaires rares qui peuvent survenir après la vaccination par un vaccin à ARNM, y compris le faible risque de myocardite et de péricardite après l'administration du vaccin qui touche principalement les adolescents et les jeunes adultes de sexe masculin âgés de 12 à 29 ans. En ce qui concerne les vaccins de rappel le Comité consultatif national de l'immunisation a tenu compte des nouvelles données probantes sur le déclin de la protection des vaccins au fil du temps et sur l'innocuité et les avantages possibles des doses de rappel du vaccin à ARNM. Dans le contexte du variant Delta, les données probantes laissent entendre que l'efficacité des vaccins contre les infections et les maladies symptomatiques diminue avec le temps et que l'efficacité des vaccins contre les maladies graves diminue probablement aussi, surtout chez les personnes âgées. Aucune autre préoccupation supplémentaire relative à l'innocuité n'a été soulevée à la suite des doses de rappel du vaccin ARNM. Le rare risque de myocardite ou de péricardite semble plus faible après la dose de rappel qu'après la deuxième dose de la série primaire. Toutefois, ce risque est plus élevé qu'après la première dose. Selon ces renseignements, le Comité consultatif national de l'immunisation a augmenté la force de ses recommandations. Il est maintenant indiqué qu'une dose de rappel d'un vaccin à ARNM autorisé contre la COVID-19 devrait être offerte 6 mois ou plus après avoir reçu une série primaire de vaccins contre la COVID-19 aux populations suivantes. Les personnes de 50 ans et plus, les adultes vivant dans des établissements qui offrent des soins de longue durée aux aînés ou dans d'autres milieux de vie collectifs avec soins aux aînés, les personnes qui ont reçu exclusivement une série de vaccins à vecteurs viraux contre la COVID-19, ce qui comprend seulement le vaccin d'AstraZeneca, Covishield et le vaccin de Janssen, les adultes qui vivent dans dans une communauté des Premières Nations, des Inuits ou des Métis qui sont issus de ces communautés et les travailleurs de la santé de première ligne ayant un contact physique direct avec les patients. Le Comité consultatif national de l'immunisation recommande en outre qu'une dose de rappel d'un vaccin à ARNM contre le COVID-19 puisse être ouverte aux adultes de 18 à 49 ans, 6 mois ou plus après la réception d'une série primaire de vaccins contre la COVID-19. Et il faut tenir compte des risques individuels et des risques des administrations. Enfin, en ce qui concerne la vaccination des adolescents et des jeunes adultes, le Comité consultatif national de l'immunisation a pris en compte les nouvelles données canadiennes et internationales qui laissent entendre que le rare risque des myocardites après avoir reçu un vaccin ARNM contre la COVID-19 peut être plus bas avec le vaccin Comirnaty de Pfizer-BioNTech 30 microgrammes qu'avec le vaccin Spikevax de Moderna 100 microgrammes. Ces données indiquent également qu'un intervalle plus long que ce qui a été recommandé auparavant entre la première et la deuxième dose de la série primaire des vaccins peut entraîner une réponse immunitaire forte et une efficacité accrue des vaccins, et que cet intervalle plus long qu'auparavant peut également être associé à un risque réduit de myocardite ou de péricardite. Par conséquent, pour les adolescents et les jeunes adultes de 12 à 29 ans, le Comité consultatif national de l'immunisation recommande maintenant d'utiliser le vaccin Comirnaty de Pfizer-BioNTech plutôt que le vaccin Spikevax de Moderna pour la série primaire de vaccins. Le Comité consultatif national de l'immunisation recommande également que la deuxième dose de la série primaire de vaccins ARNM contre la COVID-19 soit administrée 8 semaines après la première dose. Maintenant, et pendant les mois d'hiver, alors que le virus continue de circuler dans le monde et que l'importance et les répercussions du variant préoccupant Omicron sont évaluées, il faut encore faire preuve d'une vigilance accrue. Quel que soit le variant qui circule, notre protection individuelle et collective est accrue lorsque nous faisons tout en notre pouvoir pour conserver des mesures de protection. Par exemple, recevoir la série vaccinale primaire contre la COVID-19 et une dose de rappel, c'est recommandé. Porter un masque de qualité qui épouse les formes de notre visage, éviter les foules et prendre d'autres mesures, c'est possible. Merci. Thank you. Miigwech.
Merci beaucoup. On peut maintenant passer à la période de questions au téléphone. Opérateur, c'est à vous.
Thank you, merci. You may press star 1 if you have a question. Vous pouvez appuyer sur étoile 1 si vous avez une question. La première question de Raymond Fillon, TVA. La parole est à vous.
Oui, bonjour. Dr. Njoo, à quel point le variant Omicron rend nécessaire la dose de rappel? En d'autres mots, est-ce que c'est ce variant qui vous pousse aujourd'hui à recommander une dose à tous les adultes?
Non, pas du tout. Le variant préoccupant Omicron, on est en train encore d'étudier c'est quoi les implications, parce qu'il y a toujours les trois grandes questions pour n'importe quel variant préoccupant. Est-ce que c'est plus transmissible? Est-ce que ça donne une maladie plus grave? Aussi, c'est quoi les implications pour les vaccins? Mais à date, on n'a pas des réponses. Les scientifiques à travers le monde continuent avec leur travail pour avoir des réponses aux questions. Mais pour l'instant, ce qu'on voit au Canada, le variant Delta, c'est ça, le variant qui est dominant avec les virus qui se propagent, qui circulent au Canada. Et on voit aussi que notre effort avec la vaccination au Canada, c'est bien. On a bien fait. La couverture vaccinale est pas mal haut, mais on peut toujours avoir, un niveau plus haut. Et c'est très important de continuer avec nos efforts de vaccination. Ce qu'on voit maintenant avec les données probantes, c'est que on voit peut-être les premières indications que peut-être la protection à l'échelle de la population commence peut-être à diminuer. Et peut-être que plus pour les aînés, les personnes qui ont reçu la série primaire du vaccin, peut-être au début de 2020, comparé à les autres groupes d'âge, les autres sous-populations peut-être qui ont reçu leur vaccin plus tard. Donc, c'est très important maintenant parce qu'avec l'hiver, on commence aussi avec les rassemblements à l'intérieur. C'est aussi très important de souligner toutes les autres mesures de santé publique pour donner des autres couches de protection, mais le travail avec l'examination, analyse des données probantes concernant les doses de rappel, c'est déjà fait, même avant l'apparition de variants Omicron. C'est pas à cause de variants, mais c'est n'importe quel variant. On continue avec notre programme vaccinal et c'est très important de continuer avec nos efforts, avec la vaccination, maintenant avec les doses de rappel, mais aussi continuer avec les autres mesures de santé publique. Merci.
Merci. Certains disent par ailleurs que les intervalles plus longs entre l'administration des 2 premières doses, ça fait en sorte que la dose de rappel est peut-être pas nécessaire après 6 mois, qu'on devrait peut-être attendre plus longtemps. Vous en pensez quoi?
Merci pour la question. C'est une bonne question. Ce qu'on voit avec les autres pays, c'est toujours important de aussi regarder les expériences dans les autres pays. On voit que dans les pays comme Israël, les États-Unis, qui ont utilisé les vaccins avec une intervalle entre les doses peut-être plus courte selon les fabricants, que leur protection limitée à l'échelle des populations ont diminué plus rapidement. Ici au Canada, on a l'avantage, on a les bénéfices d'avoir eu en général pour beaucoup de personnes une intervalle accru plus long. Donc, je pense qu'on est encore à l'échelle de la population générale bien protégé contre la maladie grave, mais on a les premières indications que peut-être la protection commence à diminuer. Donc, je pense que c'est le bon moment pour avoir un programme de vaccination avec des doses de rappel, parce que avec les données probantes, on voit qu'avec une dose de rappel, ça peut renforcer la protection immunitaire aussi la durabilité. Et c'est pourquoi on recommande maintenant une dose de rappel. Et c'est quelque chose à suivre parce qu'on ne va pas attendre trop longtemps. Si on attend vraiment pas les données tardives qui indiquent, le taux d'hospitalisation, les décès augmentent, c'est déjà trop tard parce que si même on commence avec un programme de vaccination, ça prend au moins de 2 semaines après quelqu'un qui reçoit un vaccin d'avoir une protection. Donc, je pense que c'est le bon moment maintenant, avant les fêtes, avant que tout le monde rentre à l'intérieur, de lancer, comme on dit, un programme de vaccination incluant une dose de rappel pour les populations prioritaires. Merci.
Opérateur, prochaine question.
Thank you, merci. The next question is from Mackenzie Gray from CTV News. Please go ahead.
Hi, doctors. I'm just looking to get some clarity on why the recommendation is for people 50 and up, they should get a vaccine, but for people 50 and under, it's discretionary for a NACI recommendation. I think it's pretty clear from the language in the report, and Dr. Njoo, from what you said earlier, that it seems like it's only a matter of time for adults who are below 50 that they're going to get a vaccine. Why not get ahead of it now and recommend and open up eligibility to everyone at this point in time?
Yeah, thank you for that question, and I'll take it first. So I think our primary focus and that of the NACI recommendation is still to strongly recommend it for the groups, not only because they were at higher risk potentially for serious outcomes, but that they were immunized earlier. So the recommendation is that the booster dose should be offered 6 months or more after completion of a primary series. So both the duration of when someone has received that vaccine, as well as whether they're at higher risk of serious outcomes, are taken into account. So NACI also strengthens the recommendation over time as well as more data becomes available. As Dr. Njoo has said in French, the data that we have at the moment shows that the vaccines are holding up pretty good against severe outcomes. We're most concerned about severe outcomes in those who are elderly or have other higher risk conditions that we talked about. There is certainly a direction of travel in terms of the waning of the vaccine's effectiveness over time against asymptomatic infection and any symptoms. So that's why I think the recommendation is stratified. And for the younger people, they probably haven't reached that 6-month mark as yet.
I'd like to ask about comments of the Moderna. Sorry, go ahead.
Sorry, just one more point to add in addition to Dr. Tam's comments. Something else that was discussed by the committee was the fact that in those 50 and older, they do have increased rates of underlying medical conditions as well, which is part of what's grouped them together. Thanks.
The Moderna CEO has said that vaccines may be less effective against the new Omicron variant. What would you say to Canadians who would say, you know what, I'm going to wait on getting the original formula of the booster now and wait for a potentially new formula that could come out within a few months?
Yeah, thank you for that question. So at this current moment, Delta variant is the most dominant variant. It's like 99.8% of what we have in Canada. And so we have to mitigate the risk of this present threat. So I think the primary focus, I think as Dr. Njoo has said, is that the NACI recommendations were going to come out anyways this week, Omicron or not, to recommend the booster dose, as we've just described, to persons over the age of 18 to adults. And so I think the extent of the protection against Omicron from the primary series and booster dose remains to be seen. And we're going to learn a lot about this in the days to come. But nevertheless, it is still prudent to maximize the possibility of protection from vaccine by, first of all, offering the vaccine to anyone who hasn't had the primary series, but then offering the boosters as we've just laid out. And the Omicron variant specific vaccines are going to take months. But right now, we have the potential for a Delta surge.
Opérateur, prochaine question.
La prochaine question de Catherine Lévesque, La Presse canadienne. La parole est à vous.
Oui, bonjour au docteur. Je voulais revenir un peu sur la question de mon collègue Mackenzie. Donc, si je comprends bien, parce que la semaine dernière, il y a le ministre fédéral de la Santé qui semblait dire qu'il demandait au CCNI de statuer sur les doses de rappel en raison d'Omicron. Mais si je comprends bien, là, ça n'a rien à voir. Là. Ça allait sortir cette semaine, Omicron ou non?
Oui, donc, c'est pas la première ligne directrice de cette comité. C'est prochain chapitre. Le comité a déjà organisé les discussions concernant le booster, le dose rappel cette semaine. Donc, j'ai assuré le ministre quand il m'a demandé quand est-ce que le comité consultatif va avoir des prochaines recommandations. Je lui ai dit cette semaine. C'est vraiment à temps. It's very timely when the minister asked me the question, you know, can NACI take another look at the booster dose recommendations? I said, well, NACI is actually meeting this week already to look at the next stage of the booster recommendations. So here we are. I thank the committee and everyone who worked on it in an expedient manner. But I think everyone's been looking forward to this recommendation.
Yep. It's Dr. Njoo. I can maybe just add to what Dr. Tam has said. It's right. You know, the committee has been looking at this issue for quite some time, and it takes a while to analyze the data, looking at things such as, you know, the dose interval, what is the experience in Canada, the good level of protection we've had in the general population, and how it might be slowly diminishing, but maybe, as I said in French, maybe not at the same rate as in other countries that had that shorter dose interval. So that's all been taken into account. And now, as we said, I think it's a good time to make the recommendation, which NACI is doing today, with the booster doses, as we are now gathering insight with the winter. Lots of other things are happening, such that with the fact that we don't want to wait too long, because if we wait to get the actual data on increasing hospitalizations and other lagging indicators, then it'll be too late, because even with a vaccination program, it takes 2 weeks for an individual who receives a vaccine to actually get the maximum protection. And so all those factors have led to this moment, and it's not just because of the Omicron. It's sort of good timing as well, because it just highlights the importance of vaccination, but it's not because of the Omicron variant per se. Thanks.
Merci beaucoup pour les précisions. Je voulais aussi revenir sur le délai de 6 mois. Je voulais juste savoir sur quoi le CCNI s'est basé exactement pour déterminer ce délai-là. Est-ce qu'il y a des études ou bref des données de certains pays en particulier sur lesquels on s'est basé là-dessus? Si vous pouviez m'éclairer sur ce sujet. Merci.
OK, merci. C'est Dr. Njoo. Je peux commencer peut-être aussi Dr. Tunis et Dr. Tam pour ajouter. C'est vraiment, je pense, avec notre expérience ici au Canada, parce que nous autres, je pense qu'on est même comme des leaders pour montrer aux autres pays avec notre politique, nos programmes de déploiement de vaccins avec un intervalle accru plus long entre la première et deuxième dose de vaccin. Et on a montré que on a même eu à l'échelle de la population une protection plus forte et aussi plus durable avec un intervalle plus long. Et c'est en analysant toutes les données probantes que le Comité consultatif national d'immunisation est arrivé avec une recommandation que c'est bon d'attendre au moins 6 mois, on peut attendre même plus long, mais au moins 6 mois après l'achèvement d'une série primaire de vaccins pour avoir une dose de rappel, parce que avec même les principes de vaccinologie et immunologie très, très bien établis, on voit que c'est plus robuste et plus durable avec un intervalle plus long. Donc, c'est pourquoi on a la recommandation pour les 6 mois. Mais je ne sais pas ce que Dr. Tunis ou Dr. Tam a quelque chose à ajouter. Merci.
Oui, merci. Yeah, I can add some additional context also. So one thing to keep in mind is that the authorized intervals by the regulator are also 6 months after the second dose. So the majority of the evidence that has been generated around booster doses is looking at a 6-month interval. That was what was dominantly reviewed by Health Canada, the regulator, and also, of course, by NACI subsequently. Another thing to consider, as Dr. Njoo was saying, is that we know that intervals do matter, and they do have an influence on the nature of the immune response, the durability, and the level of the immune response. So we've seen a trend with the primary series of the first and second dose, where longer intervals can support higher effectiveness higher immune response and more durability over time. And there are also early indications from some of the literature that a sufficiently long interval between the second dose and the booster dose also results in higher antibody levels. And it might be the case that actually shorter intervals between second dose and booster dose could have lower antibody levels. So that was certainly all considered by the committee, but I think it's reasonable to say that the largest body of evidence around booster doses is looking at this 6-month interval range. So NACI is always following the evidence and keeping track and looking if there are areas where they can actually try and optimize and deviate from whatever the main body is saying if necessary. But in this case, the largest volume is at 6 months. We're seeing these indications that that longer intervals support higher immune responses. So the committee was most comfortable with 6 or more months for that booster dose. Thank you.
Merci. Opérateur, prochaine question.
Thank you, merci. The next question is from Abigail Biman from Global News. Please go ahead.
Hi, thanks for taking my question. I noted that there's a question in the report as to whether this third dose is actually a booster shot at all or whether it will eventually be considered part of the primary series. I'm wondering if you can speak more about that and whether we have a better understanding of whether Canadians may be expected to get a shot every 6 months or at some other interval, consistently going forward.
Yes, this is Theresa Tam. I'll begin and I'll look to Dr. Tunis just to supplement the answer. So I think there's a sort of subtlety to that question, and most members of the public don't necessarily understand additional doses for a primary series versus that of a booster. So because we're in the middle of a pandemic, a lot of the clinical trials were done with massive collaboration and as timely as they possibly can. So you don't actually have time to work out all of the different doses, different intervals, and look at what is the best regime for the primary series. So NACI, for example, has looked at the fact that an additional dose should be offered to those, for example, with underlying immune conditions, in terms of immunocompromised conditions, those who don't mount a good immune response, then an additional dose would be important. And that is considered part of the primary series. Whereas the booster dose is to help shore up and elevate that immune response after someone has had adequate, what we call priming of the immune system. And that's what we actually don't really know whether this third dose, for example, for some of these populations we talked about today, is truly a booster or part of what might in fact be a primary series. So it is a little bit complicated. But the bottom line is that if there is waning immunity over time, then an additional dose or boost to your immune system helps, at least in the short term, boost your antibody levels and increase the quality of your overall immune response and the durability of the response. But I think part of it is because we're doing clinical trials and observational studies as the pandemic is progressing. But Dr. Tunis, you have anything else to add?
Yeah, thank you. So I think Dr. Tam has really explained it quite well. And in the committee's analyses and in their advice to us, they've been acknowledging that this is an evolving story. And it sometimes takes years to disentangle the difference between the number of doses required to establish the most strong, well-established primary response versus that recall response or the booster where you're trying to then recall the response or augment it over time. And actually, historically, in other vaccine programs, I think it's worth noting, like for hepatitis or human papillomavirus, that the original authorized schedules did evolve over time, over years. As we learn more and there's, further study continues and we learn how to refine and optimize the schedule and the series, that's a fairly normal progression within vaccine programs. you start with what's available when the products are first authorized and the clinical trials are conducted. And then over time, we iterate, study, and evolve to try and optimize that schedule and that series, and to really use the immune system to the greatest advantage. So I think that it's important that people are aware that we'll continue to see this schedule evolve, and the committee has advised us, on numerous occasions that it's going to continue to be dynamic and evolve over time as we learn more. Also, of course, as we do consider things potentially like variant-based boosters that might be taking the immune system in a different direction over time, the interaction between a primary series and booster doses or booster series is still very much under investigation. So it's I think it's an evolving story, and it's something that the committee is acutely aware of and keeping track of. But the important thing to remember out of today's advice is that third dose or booster dose is being strongly recommended for a large segment of the population, and then is being also recommended as maybe considered for really everyone 18 and over. So it's probably not important to get too hung up on the definition of the booster versus the primary series at this time, as we know that the situation is evolving.
Thank you. I also wanted to ask, I noticed in the literature released today, if I'm reading it correctly, it says that the risk of myocarditis after the booster is lower than after the second dose, but higher than after the first dose. I'm wondering if you can expand on that, and noting that there are a lot of people still hesitant about a shot for myocarditis, if you could just speak to, how rare it is or not overall.
Yeah, so I'm happy to respond to that. So what we've seen predominantly in terms of myocarditis rates and booster doses has been evidence out of Israel, where the booster program progressed very quickly. And generally, the third dose myocarditis rates have been in the range of around 0.5 per 100,000, which is lower than the rates that we've seen out of second doses, which is more in the range of 2.4 per 100,000. So several-fold lower than the second dose myocarditis rate. So it's generally understood that that those myocarditis rates for the third dose is sitting somewhere in between the first and second dose, but it does seem to be substantially lower than the second dose, which is great news. And so the committee's been very encouraged by that, and that's informing their booster advice, and they're very comfortable moving forward with these booster doses because we know the rates are showing to be lower.
Operator, next question, please.
La prochaine question de Louis Blouin, Radio-Canada. La parole est à vous.
Oui, bonjour. La question est pour le docteur Njoo. Qu'est-ce que vous auriez à dire aux gens qui hésitent à prendre tout de suite leur prochaine dose parce qu'ils veulent attendre pour le prochain vaccin qui sera adapté au variant Omicron? Et voyez-vous un scénario où le variant Omicron pourrait devenir dominant au Canada?
Merci pour la question. Je pense qu'on a déjà souligné le point qu'actuellement ici au Canada, le variant, le dominant, c'est le variant Delta. Donc, je pense que c'est très important de souligner le point qu'avec le virus qui circule au Canada, c'est pas Omicron, c'est un nouveau variant. C'est important de prendre au sérieux pour étudier c'est quoi les implications pour la propagation. Mais à date, le variant préoccupant, c'est Delta. Et les vaccins on utilise actuellement sont très efficaces contre l'infection, mais aussi plus important, contre les maladies graves. Donc, maintenant, les recommandations aujourd'hui pour une dose de rappel, c'est vraiment pour, comme on dit, augmenter le système immunitaire et donner une bonne protection contre la COVID-19 avec la situation qu'on a ici au Canada. C'est toujours, comme on dit, une possibilité au futur, à fur et à mesure, on peut adapter, peut-être, on a peut-être des autres vaccins, peut-être adaptés pour Omicron ou des autres variants, mais ça, c'est à l'avenir. Pour la situation actuellement, c'est très important de souligner le point. C'est pas une bonne idée d'attendre pour un autre vaccin plus tard parce que Ça va prendre au moins quelques mois à la situation et c'est important de faire face maintenant à la situation aujourd'hui. Donc, ça, c'est une question. Et pour la question pour quel variant peut-être est-ce que l'Omicron va être peut-être plus dominant? On ne sait pas. On voit peut-être en Afrique du Sud, dans quelques pays, oui, peut-être ça commence à être le variant préoccupant dominant, mais c'est difficile à faire peut-être, comment dire, prendre la situation en Afrique et comparer ici au Canada parce qu'il y a beaucoup de différences des facteurs. On regarde toujours la structure, la démographique, la population, la couverture vaccinale. On voit aussi en Afrique du Sud que la couverture vaccinale, c'est plus faible qu'ici au Canada. Donc, il y a toutes sortes de facteurs. C'est aussi très important de regarder qu'est-ce qui se passe actuellement dans les autres pays en Europe, aux États-Unis et même ici au Canada. Donc, je pense que c'est quelque chose, on continue à suivre étroitement et on va s'adapter au fur et à mesure. Mais pour l'instant, pour aujourd'hui, c'est très important de souligner le point. Si vous faites partie d'une population prioritaire, et c'est vraiment les personnes âgées de 50 ans et plus, c'est une bonne idée, c'est très important d'avoir peut-être le dose de rappel. Merci.
J'aimerais vous demander, pour votre instruction concernant les 12-29 ans, vous dites que c'est préférable pour ce groupe d'âge-là d'avoir le vaccin de Pfizer plutôt que Moderna. Ma question, est-ce que les gens qui ont reçu celui de Moderna doivent s'inquiéter? Qu'est-ce que vous suggérez aux provinces? À votre connaissance, est-ce qu'il y a toujours des provinces qui utilisent ce vaccin-là dans ce groupe d'âge-là? On devine bien que oui. Ce serait quoi votre message?
Ah oui, ce n'est pas le message pour moi personnellement aux provinces et territoires. Nous sommes tous des collègues, nos homologues des provinces et territoires. On continue d'avoir des bonnes conversations et discussions en analysant comme dans l'ensemble toutes les données probantes et aussi même les orientations, les recommandations de CCNI qu'on fait la déclaration aujourd'hui. Donc, je pense pour les personnes âgées de 12 à 29 ans, c'est vraiment avec beaucoup de prudence. C'est comme c'est subtil, une recommandation. OK, peut-être on recommande le vaccin de Pfizer, peut-être comparé à le vaccin de Moderna. Mais en fin de compte, il faut toujours souligner le point que les deux vaccins, ARNM, sont très efficaces. Ils sont les deux donnent un bon niveau de protection. Même, on peut dire qu'avec les données probantes, que l'efficacité, même dans les études, peut-être l'efficacité réelle du vaccin moderne est peut-être même plus haut comparé au vaccin de Pfizer. Donc, je pense que pour peut-être les personnes plus âgées, les autres populations prioritaires, c'est peut-être une considération pour le déploiement des vaccins Moderna comparé à Pfizer. Pour les jeunes, si on a eu déjà un vaccin de Moderna, je pense que ce n'est pas une question de s'inquiéter parce que si on a eu vraiment, comme dit, peut-être l'effet secondaire de myocarditis, normalement, c'est comme la semaine après l'administration du vaccin. Donc, ce n'est pas de problème pour aujourd'hui, mais peut-être pour avancer, pour une autre dose, on recommande, comme on a déjà déclaré aujourd'hui, que c'est une considération de regarder les risques et les bénéfices de vaccin Pfizer comparé à Moderna. Mais, en fin de compte, on sait toujours que les provinces et territoires, avec leur propre programme de vaccination, ils ont tous les mêmes renseignements, informations, données probantes. Et c'est vraiment à eux à prendre les décisions éclairées pour leur propre programme de vaccination. Merci.
Merci. Opérateur, a-t-on d'autres questions au téléphone?
Oui, nous avons d'autres questions. The next question is from Laura Osman from the Canadian Press. Please go ahead.
Hey there. Thanks for taking our questions today. I wanted to start by asking you about a line in the NACI report that said that issues of global equity were taken into account when deciding on these recommendations. There was not any elaboration on that point. So I'm wondering if Dr. Tunis, Dr. Tam, maybe you could speak a little bit to why it is that we're recommending we give boosters to healthy adults in Canada as opposed to shipping those doses to other countries where vaccine rates are at like 2%.
Maybe I'll start, and then Dr. Tunis might want to comment on how NACI deliberated on the equity issue. But NACI does not just take into account science and data, they take into account other considerations as well, which includes ethics and equity. All I can say is that we need to do both. We need to be able to protect our population in Canada, using the best available science and the vaccines that we have, as well as supporting other countries. I think we can do that. NACI, as you've seen, have been quite thoughtful. They didn't just rush out and say, everybody get a booster. They've been focusing on the science and focusing on the highest risk groups. So even today's recommendation has a strong recommendation focus on the 50 plus and those with other higher risk factors. And the younger populations wouldn't have the 6 months probably until the new year for the most part. So I do think that is a balance, and it is a balance of a thoughtful, methodical approach, as well as being able to recognize and take equity into account. Dr. Tunis, I know that NACI absolutely did think about this perspective. Would you want to elaborate?
Yes, yeah, thank you, Dr. Tam. It's been very central in many of their discussions, and they're very cognizant of the the request from World Health Organization to delay booster doses as long as possible, except for those at highest risk. And that's I do agree. I think that that's what we're seeing in the advice today from the committee: an emphasis on those where the risk will be greatest and the need is greatest, and then also creating opportunities for others 18 to 49 years of age. And I think it's noteworthy that, as NACI has been continuing to monitor the evidence and to provide us this iterative advice on boosters, the last update being on October 29th, they have tried to acknowledge global vaccine equity as much as possible and really delay the use of boosters until the time when they're really perceived to be needed to get out ahead of potential outbreaks and expansions of disease in Canada. So they've been very central to a lot of the discussions, and I think that is exactly what we see reflected in the advice today.
Thank you so much. I also wanted to ask you, Dr. Tam, about something a little bit off topic on border screening for the Omicron variant. We know that the testing before and after arrival is really thorough. It's catching a lot of the incoming Omicron cases, as opposed to travel bans where, travel bans for select countries tends to be less effective, according to many experts. So what evidence is there to support doing both when testing is going to catch the vast majority of cases?
Thank you for that question. And we will also be discussing, I think, border measures later on in the day with our Minister Duclos for one of the press conferences. I think what I would say is that, at the beginning, when things are evolving rapidly, layers of precaution are taken as fast as you can, because really you're trying to buy a bit more time and to delay the spread of the virus as much as you can. As time goes on, once we gain an understanding of where this virus is in the world, then some of those measures will need to be revisited. But I think that those were the fastest measures at the beginning. But we do need to reevaluate them. At the same time, of course, then fine-tuning and escalating some of our testing protocols at the border was done simultaneously as well. And that is also being ramped up in a phased approach according to an analysis of the global risk at this time. So I think both were being implemented as quickly as possible as a precautionary approach at the start. But we will need to re-examine that as we learn more about the virus.
Merci beaucoup. En théorie, on devrait terminer la conférence de presse autour de midi, donc on aurait le temps pour une autre question, mais si les réponses sont courtes, peut-être d'autres questions suivront. Opérateur?
Thank you, merci. The next question is from Cormac McSweeney from City News. Please go ahead.
Hi. I'm just looking for, again, a little bit of clarity on the age group. So provinces can, if they're able to, offer booster shots to people 18 years and up if they choose to, because they're not bound by NACI advice. However, priority should be given to people in the age groups 50 and up, as well as all the other at-risk groups that were mentioned earlier. Correct?
That is correct, and provinces will take into account their population and their demographics and the risk factors. But that what you've said is exactly it. I think everyone has been trying to focus on the groups at highest risk, and I hope that the NACI recommendation is very helpful to the provinces and territories, and I think begins to provide some guidance as to which age groups should receive the strongest focus. But it depends on your demographics, depends on your setting in terms of your health services and your ability to access other capacities of the healthcare system. So I think provinces have a tough job in trying to balance all those things. But I think I strongly support the NACI recommendations, and all of my colleagues, the chief medical officers, will also felt that the NACI recommendation was very helpful to them as we discussed them yesterday. So I think we should be able to see provinces roll out their booster campaigns, and please do go and get your booster in that sort of 6-month time interval. It should be in a fairly thoughtful and orderly manner according to their needs.
And just as a follow-up about the 12 to 18 age group and the 5 to 11 age group, so the younger age groups, is it just simply about timelines for when they were authorized to receive the initial series of doses as to why we're not hearing a little bit more about this? Or is there a medical reason that you're not, including boosters for them at this time?
Yes, we're not including boosters at this time because they've only just started their primary series in terms of the 5 to 11-year age group. And one vaccine is now authorized for use. Kids, go get vaccinated, and the parents, please support them. But it's too early, and I think NACI will continue to monitor the evolving vaccine effectiveness over time in that age group.
Yeah, and to add additionally to Dr. Tam's remarks, it's good to keep in mind that boosters for adults were studied in clinical trials also. So there's that dimension as well, that we actually have not seen evidence yet of boosters and for example, the safety profile in adolescents or in children. So that's something that NACI will be carefully watching. And if there is a need or an urgency based on declining effectiveness or something, then there's a possibility that they could provide advice in advance of clinical studies. But we don't see that coming at this time. I think, as Dr. Tam mentioned, it's way too early to be speculating about how that will go in the end. But we know that continued study will be important to inform any decisions about boosters in those groups.
Okay, good job, questioner and doctors. We have time for one last question over the phone.
Thank you. The next question is from Matt Ingram from THCH News. Please go ahead.
Thanks very much for taking my question. I'm wondering if any of the recommendations today, and specifically the 18 to 49 recommendation, was influenced at all by the emergence of the Omicron variant.
Yes, it's Theresa Tam. I'll take that question. So NACI has been making successive recommendations on boosters. They were already scheduled to have the discussions on this next set of recommendations, regardless of Omicron. But again, I thank them for being so diligent and fast that we got a recommendation from them, having the fact that they've reviewed all the data and in such an expedient manner. So it's not because of the Omicron, but I think it's also timely because we're watching the Omicron variant.
Thanks very much. As a follow-up, do you think you could give us an example of someone in the 18 to 49 age group? What kind of situation where it would be appropriate for someone like that to get a booster shot?
Yes, I'll start, and maybe Dr. Tunis will want to add. There's different circumstances, and some people in the younger age group may have received their vaccines earlier. For example, they may be health workers or others, so they may in fact have received the vaccine quite earlier on, and they will be scoped into the group where it is strongly recommended. There are other adults in that age group that may have underlying medical conditions, immunocompromising conditions as well, and those younger adults need to discuss it with their health providers as to whether they should get the boosters now. But for the most part, most of the healthy adults 18 to 29 or 30 to 49, the recommendation is you can certainly go and get your booster, wait 6 months.
Yeah, and to add a little bit more, what what the committee has communicated in their advice is, and you'd see this in the report, that there's a table outlining considerations for jurisdictions and also for individuals about the booster decisions. And so they do outline that the risk of increased waning of protection and or lower protection could be considered by the individual, the risk of severe illness from COVID-19, which could tie into some of those medical principles that Dr. Tam was mentioning, like underlying medical conditions, older age, also racialized and marginalized populations who have been disproportionately affected due to a number of intersecting equity factors. And then the committee also identifies the risk of transmission to individuals at increased risk of severe illness as an individual consideration around booster decisions. So if you're living with or in proximity to people who are at increased risk of severe disease, then that's another consideration. So I don't think there's a single patient or individual profile that that can be really outlined, but they've set out these guiding principles that should be considered when factoring in that decision. Thanks.
Merci beaucoup tout le monde. C'est ce qui met fin à cette conférence de presse. Mes excuses à ceux qui n'ont pas eu de questions. Merci.